Welcome to another deep dive. Whether you are a medical student staring down the barrel of your final exams,
Hmm.
a junior doctor catching your breath in the break room between shifts, a public health trainee trying to map out your career, or just, an incredibly curious learner trying to make sense of the vast systems operating all around you, we are so glad you tuned in.
Absolutely, because today we're looking at something that governs almost every aspect of your physical life.
Yeah, and often in ways that are completely invisible, right? At least until the very moment something goes catastrophically wrong. We're going to explore the architecture of public health policy and the incredibly complex world of population screening in developed nations.
It's a massive topic.
It really is. So, to anchor our conversation today, I want to start with an image. I want you to picture a massive, state-of-the-art commercial aircraft. Let's say it's an A380, it's mid-flight, cruising at 30,000 feet over the ocean. This aircraft, it represents public health in a developed nation.
Hmm.
The fundamental systems, the welfare structures, the massive hospital networks, the underground basic sanitation grids, they're already built. They are the engines and the fuselage, and for the most part, they are keeping the plane in the air.
The challenge we face, though, is that while the plane is mechanically sound, the weather outside the cockpit is changing at a terrifying speed. We are no longer flying through the clear skies of the mid-20th century, where the main goal was simply avoiding infectious diseases.
Yeah, the threats have mutated.
Exactly. We're flying directly into these massive swirling storm fronts of rapidly aging populations, chronic non-communicable diseases, and highly engineered lifestyle risks.
And the really terrifying part of this scenario for any policymaker or clinician is that you cannot just land the plane to upgrade the systems. You don't get a timeout.
No, you really don't.
You have to retrofit this massive aircraft while it is still hurtling through the air at 600 miles an hour. Fixing it requires what we call upstream engineering, figuring out how to prevent the turbulence before the plane even hits it. It also requires early warning radar, which in medical terms we call population screening.
But here is the friction point. Every single modification you make to the plane shifts its weight. It costs millions, sometimes billions of dollars.
Oh, easily.
And perhaps the most difficult aspect of all is that you have to get every single passenger in the cabin, meaning the voting public and the politicians, to actually agree on the new flight path while they are actively experiencing the turbulence.
And getting that consensus is no small feat. I mean, the debates in the cabin over individual freedom versus collective safety can get incredibly heated. And those debates fundamentally alter the mortality statistics of entire nations.
They dictate who lives and dies, literally.
Okay, let's unpack this. Our structural spine for this conversation comes from a truly foundational text that many of you are likely reading right now. It's the Oxford Textbook of Global Public Health. We are zeroing in on two massive, interrelated pillars from this work. First, the complexities of public health policy in developed countries. And second, the science, the math, and the deep controversies of population screening.
Our mission over the next hour is to build a highly durable conceptual framework for you. We are not going to sit here and just recite lists of historical facts or memorize dates.
Yeah, nobody needs that.
Right. Instead, we want to connect the dots. We want to draw a straight line from underlying risk to environmental exposure to policy intervention and finally to system-wide impact. We're going to explore exactly why some high-income nations manage to succeed brilliantly at extending life while others spectacularly fail at managing chronic diseases despite spending absolute fortunes.
Yeah.
And from there, we'll take a very deep analytical dive into what is arguably the ultimate and most misunderstood policy intervention of our time: population screening. We will unpack the paradoxes, break down the complex math step by step, and navigate the very heavy ethical dilemmas that arise when you go searching for disease in healthy people.
So let's zoom out and look at the macro landscape. We often operate under the assumption that wealth automatically equals health, that if a country has enough money, its citizens will naturally live longer. But the epidemiological data tells a much stranger story.
It really does.
Let's define our scope first. When the research refers to developed countries in the context of this specific data set, it's looking at a well-defined cohort. 31 high-income OECD members alongside 6 European Union nations. So we have a basket of 37 highly resourced countries. If you track the mortality data across these nations from roughly 1970 to 2010, you see a mind-bending divergence.
The contrast is stark.
Take child mortality, the probability of a child dying before their 5th birthday. Across all 37 countries, there was a staggering, almost universally identical drop. The data on Portugal is a perfect illustration of this. Back in 1970, Portugal's child mortality rate was sitting at about 7.4%. By 2010, over just 4 decades, it had plummeted to 0.3%.
That's a 96% reduction.
Exactly. They essentially eradicated that specific category of risk. But then you flip the page and look at adult mortality, which is defined as the probability of a 15-year-old dying before they reach their 60th birthday. Suddenly, the neat universal success story shatters into a chaotic, fragmented picture. Some countries improved steadily, others stagnated, and a few actually went backward.
The underlying mechanisms behind that divergence are fascinating. We have to ask why child mortality was such an easily replicated victory across drastically different political systems, while adult mortality became this intractable localized crisis.
What's the textbook answer there?
The successes in child health were primarily driven by scientific advances that were easily packaged, diffused, and seamlessly integrated into existing state apparatuses. We are talking about the mass production of vaccines, the chlorination of water supplies, and basic maternal education programs. Implementing these interventions was essentially a centralized, top-down policy win.
Right.
A health ministry manufactures a vaccine, distributes it to local clinics, mandates it as a prerequisite for school enrollment, and within a few years, the mortality rate plummets.
The critical detail there is the lack of required behavioral friction. A 5-year-old doesn't have to fundamentally alter their daily habits or their psychology to benefit from a measles vaccine or clean tap water. The state engineers the safety net, and the child simply exists within it.
That is the crucial distinction. Adult mortality, particularly from the 1970s onward, evolved into an entirely different beast. The primary threats shifted away from pathogens and toward non-communicable diseases, or NCDs. The modern killers became cardiovascular disease, strokes, emphysema, and various cancers.
And the vectors for these diseases aren't microbes. They're behavioral and environmental risks.
Precisely. We are talking about the mass consumption of tobacco, heavy alcohol use, highly processed dietary compositions, and the normalization of high-speed motor vehicle traffic.
Yeah.
You cannot mandate a vaccine against a head-on car collision, and you cannot permanently chlorinate away the effects of a high-sodium diet.
This shift, this epidemiological transition from infectious to chronic disease, it really exposed the structural flaws in certain types of governments. There's a deeply tragic case study in the literature regarding the collapse of adult health in the Eastern Bloc, the Soviet and post-communist states. You'd think a highly centralized, authoritarian state would be able to just dictate healthy behaviors, but they suffered a catastrophic failure in adult life expectancy.
To grasp why that happened, we have to examine the Semashko system. This was the health infrastructure named after Nikolai Semashko, the first Soviet Commissar of Public Health. It was a massive, incredibly robust network of sanitary epidemiological stations spread across the Soviet sphere.
And initially it worked well, right?
Oh, in the first half of the 20th century, this system was an absolute juggernaut. It was highly effective at rolling out vaccines, quarantining outbreaks, and conquering the infectious diseases that were ravaging the post-war population. But when the threat matrix changed to chronic, non-communicable diseases, the Semashko system was caught completely flat-footed.
So what was the blind spot? If they had this massive network of health stations, why couldn't they just pivot their resources from fighting typhus to fighting heart disease?
The system suffered from 3 fatal structural flaws. First, it was overwhelmingly clinician-dominated. The entire apparatus was designed around the idea of a sick patient walking into a clinic and a doctor treating the acute symptoms. There was almost no mechanism for population-level upstream prevention of chronic illness.
Okay, so it was entirely reactive.
Exactly. Second, the Eastern Bloc was largely isolated from what medical historians call the global quantitative revolution. While researchers in the UK and the US were developing modern epidemiology, running massive randomized controlled trials and longitudinal studies that linked invisible risk factors like high blood pressure and smoking to future heart attacks, the Soviet medical establishment was largely left out of that data revolution.
They simply didn't have the analytical radar to see the new threats forming. They were fighting a war of attrition without military intelligence.
That's a great way to put it. Furthermore, they were hamstrung by a much deeper ideological block: their political economy. The Soviet model placed the highest possible premium on physical engineering. Success was measured in heavy industry, steel quotas, building massive hydroelectric dams, and taming the natural environment.
So human health was an afterthought.
The biological well-being of the individual was secondary to the industrial output of the state. Science was severely compartmentalized. A public health official in a sanitary epidemiological station had absolutely no political power to walk into the Ministry of Agriculture or the Ministry of Industry and tell them that their production quotas were killing the adult workforce.
I imagine it's also a terribly tough sell to promote dietary prudence and calorie restriction to a population that's already standing in bread lines and dealing with chronic consumer shortages.
The psychological environment simply couldn't support lifestyle interventions.
Hmm.
As a result, while Western Europe spent the 70s and 80s watching their adult mortality rates steadily decline, many post-communist states actually recorded a horrifying increase in adult male mortality. It's one of the starkest examples in modern history of how political and administrative structures literally dictate who lives and who dies.
Now, it's easy to look back at the Soviet Union and view that as an isolated historical quirk of the Cold War. But the data forces us to look in the mirror, specifically at the United States, because the statistics here present an incredibly stubborn paradox.
They certainly do.
By almost every financial metric, the United States is the undisputed heavyweight champion of healthcare funding. It spends vastly more per capita than any other nation. It houses the most advanced biomedical research facilities on the planet. And yet, when you look at the epidemiological data, comparing the U.S. to its high-income peers, American adult mortality lags roughly 20 years behind.
It's a sobering statistic.
To put numbers to that, traffic fatalities in the U.S. are about 65% higher than the reference group of comparable nations. Years of life lost specifically to cardiovascular disease are roughly 34% higher. So for a trainee or a junior doctor looking at this, the obvious question is, how can a system with seemingly infinite resources produce such comparatively poor population-level outcomes?
Exploring that discrepancy requires us to look strictly at the political determinants of health. And it's vital that we approach this analytically, remaining entirely neutral. We are not evaluating whether a specific political ideology is morally good or bad. We are simply tracing the epidemiological outcomes that result from different styles of governance.
Right. Just looking at the textbook data?
Exactly. The historical analysis suggests that the United States struggles to implement sweeping public health policy precisely because of its foundational, liberal, and libertarian political economy.
Meaning, the cultural and political DNA of the country is hardwired to prioritize individual autonomy and freedom of choice above almost all other concerns.
Yes. The underlying architecture of the U.S. model is heavily influenced by neoclassical and Austrian economic theories. In this framework, there's a profound systemic suspicion of state-coerced interventions. The prevailing cultural assumption is that individuals are rational actors.
So if you give them the data, they'll make the right choice.
That's the belief. The belief is that if you provide people with accurate information in a free market, they should be entirely free to make their own risk assessments. If an adult wants to smoke a pack of cigarettes a day, consume a diet heavy in ultra-processed foods, or choose not to wear a motorcycle helmet, that is viewed as an exercise of personal liberty that the state has no business infringing upon.
But wait, to play devil's advocate here, doesn't that model have a philosophical point? If we strip away the medical jargon, isn't that just the basic definition of freedom? If I am a fully informed adult, shouldn't I have the right to make terrible choices about my own body as long as I'm not directly harming someone else? How do public health frameworks reconcile that desire for individual liberty with the drive to improve population statistics?
That is the central tension of modern public health, and different regions resolve it differently. While the U.S. leans heavily into individual risk, the European approach generally leans toward what the literature describes as piecemeal social engineering. European states tend to demonstrate a much higher threshold of willingness to utilize state mechanisms such as aggressive taxation, stringent corporate regulation, and meticulous urban planning to actively shape the environment.
They aren't just giving people information. They are subtly and sometimes forcefully editing the choices available to them.
They attempt to balance individual autonomy with a robust concept of social solidarity. They operate on the premise that an individual's choices are never made in a vacuum. They're shaped by the environment. And the epidemiological data over the last 50 years clearly indicates that when dealing with non-communicable diseases and behavioral injuries, the European model of piecemeal social engineering has yielded significantly lower adult mortality rates.
So if the data suggests that environmental engineering is the key to lowering adult mortality, how does a country actually execute that? How do you transition from an abstract philosophy to boots-on-the-ground policy that saves lives? Let's move from the macro theory into some concrete historical case studies. The literature highlights three massive triumphs in public health engineering: the battles against traffic fatalities, tobacco consumption, and cardiovascular disease.
All brilliant examples of systems thinking.
Let's start with traffic because the history here is fascinating. In the early 1970s, an academic named R.J. Smead published an observation that became known as Smead's Law. He looked at massive data sets of motorization across different societies and found a really counterintuitive mathematical trend. He discovered that as a society becomes more motorized, meaning as the sheer number of cars on the road increases, the number of traffic fatalities per vehicle naturally begins to decline.
At first glance, that feels backward. You would logically assume that more multi-ton steel machines moving at high speeds would automatically equal a proportionally higher rate of death.
Exactly what I thought. But Snead's data showed that societies undergo a natural process of familiarization with a new hazard. When cars first flood a city, it's chaos. But over time, the culture adapts organically. Pedestrians learn to instinctively look both ways before stepping off a curb. Drivers develop better spatial awareness. The baseline norms of survival just naturally evolve.
Right.
But the most crucial takeaway from Smead's work wasn't just that this natural learning curve exists. It was that smart public policy can massively artificially accelerate that curve. And the absolute masterpiece of this acceleration happened in the state of Victoria, in Australia.
The Victoria model is mandatory reading for anyone interested in systems thinking. They looked at the carnage on the roads and decided that merely pleading with the public to drive safely was a catastrophic failure of imagination. They realized they needed to engineer the system so heavily that driving safely became the path of least resistance.
We didn't hold back.
They started aggressively.
Yeah.
In 1970, Victoria became the very first jurisdiction on the entire planet to legally mandate the wearing of seatbelts.
Which, as we know from historical accounts, was initially met with massive public resistance. People felt it was an infringement on their personal space inside their own property. But the state held firm, and they kept pushing the envelope. In 1976, they introduced random breath testing for alcohol.
The introduction of random breathalyzers was a watershed moment. Before this, police generally only tested drivers who were already driving erratically or who had just caused a crash. Victoria changed the paradigm. They set up checkpoints to test completely asymptomatic, seemingly normal drivers at random. But the true genius of the Victoria model wasn't just the police enforcement. It was the financial architecture they built underneath it. In 1986, they established the Transport Accident Commission, or the TAC.
This is where the policy becomes incredibly elegant. The TAC was instituted as a mandatory no-fault compensation levy. Every single person who registered a motor vehicle in the state had to pay an insurance premium into the TAC. In return, if you were injured in a motor vehicle accident, the TAC covered all of your medical care, your rehabilitation, and your lost wages.
The critical element there is the phrase, no fault.
Right, and this is the part I struggled with initially. If the state pays for my medical bills, regardless of whether I caused the crash by speeding or if I was totally innocent and got rear-ended, doesn't that create a moral hazard? Doesn't a no-fault system actually encourage reckless driving because the financial consequences are removed?
You might assume that, but the TAC fundamentally flipped the incentives at the institutional level. Because the TAC was now legally obligated to foot the massive medical bills for every single crushed pelvis, traumatic brain injury, and spinal cord rehabilitation in the state, they suddenly possessed a massive, direct, existential financial incentive to ensure those injuries never happened in the first place.
They became financially liable for the population's behavior.
Exactly. The legislation actually required a portion of the tax funds to be aggressively reinvested into injury prevention and the independent scientific evaluation of those prevention efforts.
They basically weaponized their own insurance premiums. They took the money they were saving by reducing legal battles over fault and poured it into prevention. They funded state-of-the-art accident research centers. They produced incredibly visceral, hard-hitting television campaigns that changed the cultural conversation around drunk driving. And they funded the police to enforce the laws at an unprecedented scale.
By the late 2000s, in a state with a population of just over 5 million people, the police were conducting well over 1 million random breath tests every single year.
The omnipresence of the enforcement completely changed the psychology of the driver. If you went to a pub in Victoria, you didn't ask yourself, am I too drunk to drive? You ask yourself, what are the statistical odds I will encounter a random breath test on my way home?
And because the TAC had funded the police so heavily, the answer was always, the odds are too high to risk it. They transformed traffic safety from a moral plea into a relentlessly optimized self-funding system. And the result was a spectacular, sustained plunge in road fatalities.
It's an incredible victory for social engineering, and we see a very similar, albeit much slower, evolution when we look at the history of tobacco control. To understand the tobacco timeline, you have to realize that public health messaging had to undergo a fundamental identity shift.
Right, from infectious to behavioral.
Exactly. In the early 20th century, public health campaigns were almost exclusively focused on infectious disease vectors. Think of the old signs everywhere saying, "Don't spit on the sidewalk." The goal was to stop the spread of the tuberculosis bacillus. But with tobacco, the messaging had to pivot toward restricting adult behavioral autonomy. The message became, "Don't smoke." And society did not accept that transition easily.
Not at all.
Let's trace the timeline, because it highlights how agonizingly slow policy can be. In the 1950s, you have researchers like Richard Dahl and Austin Bradford Hill publishing their landmark epidemiological studies in the UK, drawing a definitive, undeniable statistical link between smoking and lung cancer.
Yet the policy response was practically glacial. The scientific proof was there in the 50s, but it took until 1962 for the UK's Royal College of Physicians to bypass the government entirely and release their own landmark public report detailing the dangers. And it wasn't until 1964 that the U.S. Surgeon General released a similar report.
Why the massive delay? If the science was settled, why didn't governments immediately ban the product or heavily regulate it?
The inertia was driven by a combination of profound economic reliance and political philosophy. On the economic side, Treasury departments across the developed world have become deeply addicted to the massive tax revenues generated by cigarette sales. To severely restrict tobacco meant blowing a massive hole in national budgets.
And the political side?
On the political side, as the historical analysis notes, the idea of the state stepping into the private lives of adult citizens to tell them to abandon a legally purchased, culturally ubiquitous habit was viewed as an extreme, almost tyrannical overstep of government power at the time.
But the medical community didn't give up. They just changed tactics. They started playing the long game. Let's jump forward to 1987, and we find ourselves back in Victoria, Australia. The state government passes the Victorian Tobacco Act, and they execute a brilliant legislative maneuver. They instituted a hypothecated tax.
A ring-fence tax.
Right, a dedicated tax,
Yes.
specifically levied on wholesale tobacco sales.
And they used the revenue from that specific tax to establish a health promotion foundation.
Hmm.
What did that foundation do? It systematically hunted down and bought out the tobacco industry's most powerful marketing tools. For decades, tobacco companies had sponsored massive sporting events, cricket matches, and arts festivals, intertwining their brands with health, vitality, and national identity.
They were everywhere.
The Victorian government used the tobacco tax money to replace the cigarette branding at these events with public health promotion messages.
They forced the tobacco industry to essentially fund its own eviction from the public square, and that slow, relentless tightening of the screws continued globally. The culmination of this strategy, at least in the modern era, occurred in 2012 when Australia became the first nation to mandate plain, standardized packaging for all tobacco products, stripping away the industry's final mechanism for brand appeal.
And if we look at cardiovascular disease, or CVD, we see another vital piece of the policy puzzle: community mobilization. The foundational science for CVD began in earnest in 1948 when the U.S. passed the National Heart Act. This legislation provided the funding for massive epidemiological tracking projects, most notably the Framingham Heart Study.
Which fundamentally changed medicine.
It was revolutionary because it gave the medical world the concept of risk factors. Before Framingham, doctors didn't really understand that asymptomatic variables like high blood pressure or elevated serum cholesterol were precursors to future heart attacks.
Framingham gave us the map. It showed us what was killing people. But identifying a risk factor in a lab in Massachusetts doesn't automatically stop a man in Europe from having a heart attack. Knowing the science isn't the same as changing the behavior.
Precisely the problem. And to solve the behavioral equation, we have to look at the North Karelia project in Finland. In the early 1970s, the North Karelia region had some of the highest rates of premature cardiovascular death in the entire world. The traditional public health approach would have been to print thousands of pamphlets, telling people to eat less saturated fat, leave them in doctors' waiting rooms, and hope for the best.
Which we know is almost completely ineffective.
Completely. So the leaders of the North Karelia project took a radically different approach. They launched a massive, deeply integrated community mobilization effort. They didn't just talk to doctors, they engaged the local housewives associations who were doing the cooking. They negotiated with the local dairy farmers and food producers to change the composition of the food being manufactured.
Wow, they went right to the source.
Yes. They integrated nutritional education directly into the school curriculums. They fundamentally altered the dietary culture of the region, shifting the population away from heavily butter-based diets toward healthier alternatives. And they did it by weaving the intervention into the very social fabric of the community. It remains the gold standard for how you execute true grassroots prevention.
If we connect this to the bigger picture when we step back and look at these three distinct victories, the engineered enforcement of traffic safety, the slow legislative strangulation of tobacco marketing, and the grassroots cultural shift in cardiovascular diets. What is the common thread? What is the secret formula for successful public health policy?
The historical analysis reveals a very consistent sequential pattern. First, everything rests on rigorous, undeniable scientific discovery. You must identify the true hazard. Second, you invariably need relentless professional advocacy, often from medical bodies who are willing to bypass hesitant politicians and speak directly to the public.
Right, like the Royal College of Physicians.
Exactly. Third, you must build a vocal public constituency. The voters have to demand the change. Fourth, there must be decisive legislative action, usually involving structural regulation or targeted taxation. And finally, you need continuous independent evaluation of the outcomes to prove the intervention is working. It is never a quick fix. It is a multi-generational war of attrition.
That perfectly sets up the next massive topic we need to tackle. If broad policy and taxation are the upstream engineering we use to steer the plane, then population screening is the early warning radar we install in the cockpit. Screening is arguably the ultimate, most sophisticated policy tool available to a developed health system. But it's also, without a doubt, the most wildly misunderstood by both the public and by many practicing clinicians.
It really is.
Before we dive into the deep end of the math, we have to establish an incredibly precise vocabulary. The literature demands that we strictly differentiate between three distinct concepts that people and even doctors constantly mix up: screening, case finding, and surveillance.
This semantic precision is vital because the ethical rules governing each are completely different. Let's define them clearly. Screening is the systematic, organized application of a specific test to a large population of people who presume themselves to be entirely healthy.
You feel fine.
Right. They have absolutely no symptoms, they're living their normal lives, and the health system actively invites them in to look for hidden, latent disease. A national breast cancer mammography program or a coordinated cervical cancer smear program are prime examples of screening.
Okay, so the key there is that the patient is asymptomatic and the system initiates the contact. What about case finding?
Case finding, which is also frequently called opportunistic testing, occurs when a patient has already initiated contact with the healthcare system, either for a specific complaint or a routine checkup, and the clinician decides to offer a test based on that individual's specific profile.
Give me an example of that.
For instance, imagine you are a junior doctor. A 60-year-old man comes into your clinic complaining of nocturia. He is waking up 4 times a night to urinate. Based on his age and his symptom, you offer him a prostate-specific antigen, or PSA, blood test. That is case finding. You are investigating a specific complaint in a specific individual.
That makes perfect sense. And what about surveillance?
Surveillance is the continuous, broad, population-level tracking of disease trends. The primary goal of surveillance is not necessarily to intervene and treat the specific individual being tested. Rather, the goal is to gather aggregate data to inform wider public health action. Tracking influenza strains through community swabbing or monitoring wastewater for viral loads is surveillance. You are measuring the burden of disease in the community, not managing an individual patient's care plan.
This distinction is so critical because when you are conducting population screening, when you are sending letters to millions of healthy people and asking them to undergo a medical procedure, the ethical bar you have to clear is astronomically high. You are intervening in healthy lives, which means your test better be incredibly good.
It has to be virtually bulletproof.
And that brings us to this statistical engine of screening. We need to talk about the math of the net we are casting. Let's define the two foundational metrics of any test: sensitivity and specificity.
These two metrics define the intrinsic technical performance of the test in a laboratory setting. Sensitivity is a measure of the test's ability to correctly identify all the people who actually have the disease. It's the true positive rate. If you have a room with exactly 100 people who are genuinely sick, and your new swab catches 95 of them, your test has a sensitivity of 95%.
And what about the people who aren't sick?
That is where specificity comes in. Specificity is the test's ability to correctly identify all the people who do not have the disease. It is the true negative rate. If you have a room with 100 perfectly healthy people and your test correctly clears 95 of them by returning a negative result, your test has a specificity of 95%.
Now, here is where the psychology of medicine crashes into the mathematics of epidemiology. If you talk to almost any clinician whose daily job involves treating sick patients, they naturally obsess over sensitivity. Their entire professional mindset is, I have a potentially sick patient sitting on the exam table right in front of me. I absolutely cannot miss a case.
Naturally, they want to help the person in front of them.
Right. They're terrified of a false negative. Therefore, they desperately want a highly sensitive test, even if it is a bit hyperactive and throws up a few false alarms, because their primary goal is to catch everything. But let me ask you this. When we transition from treating an individual patient in a clinic to designing a population-wide screening program that targets millions of healthy people, is sensitivity still the most important metric?
Emphatically, no. And this is the hardest concept for many to grasp. In the realm of population screening, specificity is actually the supreme virtue. Specificity is the shield that protects the health system from collapsing under its own weight.
Why is that?
The reason for this comes down to the brutal math of disease prevalence and a concept called positive predictive value, or PPV.
Okay, we need to slow down and walk through this math step by step because this calculation is the ultimate aha moment for understanding why seemingly great screening ideas can be incredibly dangerous in practice. Let's build a hypothetical scenario. Let's say we are dealing with a disease that has a prevalence of 0.1% in the general population.
Meaning exactly 1 in 1,000 people actually have the disease.
Right. Now let's pretend the brilliant scientists in the lab have developed an amazingly advanced test for it. The test operates with 95% sensitivity and 95% specificity. If I'm a politician and a scientist tells me they have a test that is 95% accurate across the board, I'm thinking, fantastic, let's roll it out to everyone.
That is exactly the trap. Let's see what happens to the math when we roll that 95% accurate test out to a medium-sized city of 100,000 presumed healthy people. We start with the true positives. Because the prevalence is 0.1%, we know that out of our 100,000 people, exactly 100 of them actually have the hidden disease.
Okay.
Our test is 95% sensitive, so it will correctly identify 95 of those sick people. We have 95 true positives. That's the good news.
Right. We found 95 people who need help, but we still have 99,900 perfectly healthy people waiting for their results. What happens to them?
This is where the 95% specificity reveals its dark side. The test will correctly clear 95% of those healthy people. They will get a letter saying they are fine. But by definition, the test will incorrectly flag 5% of those completely healthy people as having the disease.
Wait, let me do that arithmetic. 5% of 99,900 healthy people, hang on, that is 4,995 people.
Correct. You have just generated 4,995 false positives.
Okay, so let's look at the mailroom of the hospital. We are sending out letters to everyone whose test came back positive. How many total positive letters are we mailing? We have the 95 true positives we caught, plus the 4,995 false positives we accidentally flagged. That is a total pile of 5,090 positive results.
Now, we calculate the critical metric, the positive predictive value. The PPV asks a very simple question from the perspective of the patient. If I receive a letter saying my test is positive, what is the actual percentage chance that I truly have the disease? To find the PPV, you divide the true positives by the total number of positive results.
So that's 95 true positives divided by 5,090 total positives, which equals roughly 1.9%. I really want you, the listener, to let that sink in. We took a test that is 95% accurate in the lab. But because the disease prevalence was low, when we applied it to the general population, the positive predictive value plummeted to 1.9%. That means if you are sitting at your kitchen table and you open a letter from the health department saying your screening test came back positive, there's only a 1.9% chance you are actually sick.
Which conversely means that 98 out of 100 people who get a positive letter are experiencing a false alarm.
It's staggering.
I often compare this to installing an incredibly sensitive car alarm on your vehicle. Yes, if someone shatters the window with a brick, the alarm will go off. It caught the burglar.
Yeah.
But if the alarm also goes off every single time a gentle breeze blows, or a heavy truck drives past, or a leaf falls on the hood, what happens?
You just stop listening to it.
Exactly. Eventually, the neighborhood goes crazy from the noise, you stop checking to see if you're actually being robbed, and the system becomes entirely useless. In medicine, those 98 false alarms aren't just an annoyance. Those 98 healthy people are now terrified.
Because they think they're sick.
They are immediately thrust into the acute medical system. They are scheduled for further invasive testing. They undergo unnecessary tissue biopsies, they are subjected to CT scans with radiation, and they deal with weeks of extreme psychological anxiety, all because the specificity of the test couldn't handle the sheer volume of healthy people.
This is why specificity is the shield. If you are casting a net over millions of healthy people, even a microscopic false positive rate will generate enough false alarms to completely overwhelm your clinics and bankrupt your health system with unnecessary follow-up care.
And the literature provides a brilliant, real-world example of how to elegantly solve this math problem.
Right, with beta thalassemia.
Yes, which is an inherited blood disorder.
Mm.
When public health officials first tried screening for this, they used a primary blood marker called mean cell hemoglobin, or MCH, which essentially measures the amount of oxygen-carrying protein inside red blood cells. If they set the diagnostic cutoff very generously at 27 picograms, the test achieved 100% sensitivity.
So they missed absolutely no one who had the trait.
Correct. But in regions where the prevalence of thalassemia was low, the positive predictive value collapsed to just 1.3%. The clinics were drowning in false positive alarms.
So how did they fix the car alarm? They didn't change the sensitivity. They layered on interventions to massively boost the specificity. Before running the expensive blood work, they simply added a standardized family origins questionnaire to assess baseline genetic risk. Then, for the blood work, alongside the MCH, they estimated a secondary, more specific marker called HbA2.
By combining the questionnaire with the dual marker blood test, they maintained their excellent detection rate, but they filtered out the noise. In one documented implementation, the systems thinking approach reduced the need to recall the partners of pregnant women for follow-up genetic testing by a staggering 96%.
They saved the health system thousands of hours of unnecessary clinical work, and they saved thousands of expectant parents from weeks of terrifying, unnecessary panic. Which leads us perfectly into the broader economics, ethics, and governance of screening. Because as we've just proven with the math, a poorly designed screening program doesn't just cause individual anxiety. It has the potential to actively destroy the functional capacity of a health system.
To prevent that, the global health community relies on a strict set of rules. Back in 1968, the World Health Organization published what are known as the Wilson and Jungner criteria. These are the foundational commandments for deciding when it is appropriate to launch a screening program. Over time, national bodies, like the UK National Screening Committee, have expanded and refined them.
They act as gatekeepers, right?
These criteria are incredibly rigorous, and they are designed to act as a gatekeeper against overenthusiastic testing. They dictate that the disease being screened for must be an important, recognized public health problem. The natural history of the disease, meaning exactly how it develops from a latent, invisible phase into declared symptomatic illness, must be comprehensively understood by science.
And the test itself.
There must be a simple, safe, precise, and validated test available. And crucially, there is a golden rule. There must be an accepted, effective treatment ready and waiting for the patients you find. There is absolutely no ethical justification for screening a population to find a disease if you have no capacity or methodology to treat it. You are simply giving people a death sentence with no hope of intervention.
And beyond the clinical criteria, there is the brutal reality of health economics. When public health economists evaluate a proposed screening program, they aren't just looking at the wholesale cost of the chemical swab or the price of drawing a vial of blood. They are analyzing the opportunity costs of the entire logistical machine.
This is a critical concept for trainees to grasp. The true financial footprint of a screening program is immense. It includes the cost of building massive, secure IT infrastructure to track millions of citizens. It includes the administrative armies required to run the fail-safe call and recall systems to ensure no one slips through the cracks. And, as we discussed with the PPV math, it includes the enormous downstream clinical costs of performing thousands of unnecessary surgical biopsies to investigate all the false positives.
And how do economists measure that value?
In the language of health economics, we quantify value using metrics like QAY's quality-adjusted life years and DALY's disability-adjusted life years. A QAY is essentially a mathematical way to measure both the quantity and the quality of life generated by a medical intervention. 1 QAY equals 1 year of life in perfect health.
So, if a health system has a finite budget, which all systems do every single dollar and every single hour of a specialist surgeon's time, that is spent chasing down a false positive generated by a sloppy screening program, is $1 in an hour that is fundamentally stolen from treating a different patient who is genuinely visibly sick right now.
Exactly.
If a surgeon is spending their afternoon biopsying a benign cyst found by a false positive screen, they are not spending that afternoon performing a hip replacement on a patient who is currently in agonizing pain. The opportunity cost of a bad screen is the actual health outcome foregone somewhere else in the hospital.
This raises an important question. It forces us to confront the deep ethical tensions inherent in screening. We constantly run into the classic philosophical battle between utilitarianism and equity. Consider the debate between universal screening and targeted screening.
How do those differ ethically?
From a purely utilitarian economic perspective, targeted screening, where you only test specific high-risk demographic groups, gives you the most QALYs for your money. It's cheap and efficient. But ethically, targeted screening can be highly stigmatizing to the minority groups being singled out. On the other hand, universal screening, testing absolutely everyone regardless of background, appeals to our sense of fairness and equity. But it is astronomically expensive, highly inefficient, and strains the resources of the entire system.
There is also the incredibly thorny ethical issue of informed choice. The literature argues, quite convincingly, that in many modern routine screening programs, true informed choice is largely an illusion. A citizen receives an official-looking letter from the government telling them it is time for their routine scan. The language is often inherently persuasive.
They assume it's good for them.
Right. The individual naturally assumes that because the government is offering it, the test must be entirely beneficial and harmless. But for a patient to give truly informed medical consent, they need to understand a metric called the number needed to screen.
The number needed to screen is a sobering statistic. It tells you how many people have to undergo the testing procedure to prevent just one single death from the disease. For example, when evaluating breast cancer mammography for women in their 50s, certain epidemiological estimates suggest that the number needed to screen over a 5-year period is roughly 2,451.
Think about what that number actually represents in reality. That means 2,451 women need to take time off work, travel to a clinic, undergo the physical discomfort of regular mammograms, and collectively absorb all the associated psychological anxiety, false positives, and potential surgical biopsies, all so that one single life within that massive group can be saved.
If a clinician doesn't communicate those specific odds to the patient, if they just say, "This test saves lives," then the patient's consent isn't genuinely informed by the reality of the risks they are undertaking.
And we must also acknowledge the historical shadow that hangs over this entire field, particularly regarding antenatal and genetic screening. Early 20th century eugenics movements, which sought to selectively breed populations based on flawed and deeply racist genetic theories, cast a long, dark, historical shadow.
The historical analysis emphasizes that the governance of genetic screening cannot merely be a technical or medical exercise. It must be a societal one. We must build firewalls to ensure that screening technologies are exclusively used to empower individual reproductive choice and treat disease, and are never co-opted for state-sponsored social engineering.
There is a deeply painful historical example of how getting the societal governance wrong, even with the best of clinical intentions, can cause immense harm. In the United States in 1970, the government passed the Sickle Cell Act. The clinical goal was noble: identify individuals carrying the sickle cell genetic mutation so the medical system could provide better targeted care.
But they rolled it out as a massive, sweeping screening program without laying any of the necessary groundwork regarding public education or societal preparation.
What happened?
It was an unmitigated disaster for the very community it was screening to help. Because the public education was non-existent, the general public and, crucially, many employers and insurance companies fundamentally confused what the test meant. They didn't understand the difference between being a perfectly healthy carrier of the sickle cell trait, meaning you just have one copy of the gene and no symptoms, and actually suffering from sickle cell disease, where you have two copies.
So they panicked.
Perfectly healthy individuals who were merely carriers faced sudden, extreme stigmatization. They were viewed as being inherently sick. Some lost their jobs. Others were denied life insurance policies. The social damage was so severe that it created a massive backlash, and the public eventually began refusing the testing altogether.
It's the ultimate proof that you can get the biochemistry perfectly right in the lab. But if your societal governance and public communication fail, the screening program will actively harm the population. Let's trace how these screening principles apply across the actual human lifespan. We will look at screening across the life course and wade into some of the greatest controversies in modern medicine. Let's start at the very beginning: antenatal and newborn screening. Within days of birth, we screen newborns for a variety of severe metabolic and genetic conditions. A classic example is PKU, or phenylketonuria.
For those who might need a quick refresher on their genetics, PKU is a rare inherited disorder where the baby is born missing a crucial enzyme needed to break down an amino acid called phenylalanine, which is found in all dietary protein. If a baby with PKU drinks normal milk, the amino acid rapidly builds up to toxic levels in the blood, causing severe irreversible brain damage and severe intellectual disability.
But the miracle of the PKU screen is that if you catch it immediately via a heel prick blood test in the first few days of life, you simply switch the baby to a highly specialized phenylalanine-free diet, and they grow up with entirely normal cognitive development. It is one of the greatest victories in public health history.
But the textbook literature emphasizes a critical logistical vulnerability here. The biochemical test is useless without a fail-safe IT system. Identifying a baby with PKU in the laboratory accomplishes absolutely nothing if the lab report gets lost in the mail or the administrative clerk types the phone number incorrectly and the baby is lost to follow up before the dietary intervention begins.
The tech has to be perfect.
In newborn screening, the speed and infallibility of the information technology system is just as vital to the child's survival as the accuracy of the blood test itself.
The clarity of newborn screening is relatively straightforward. You find the defect, you change the diet, you save the brain, but the clarity completely vanishes when we move into adulthood and begin dealing with the heavy, fierce debates surrounding adult cancer screening. To even begin to understand why doctors argue so passionately about cancer screening, we have to define two incredibly important epidemiological biases. These are structural illusions that trick our brains into thinking a screening program is vastly more successful than it actually is.
These concepts are absolutely essential for any clinician to master. The first is called length time bias. To visualize this, imagine that cancer tumors are a basket of mixed animals. Some tumors are incredibly aggressive and fast-growing. Let's call them rabbits. Other tumors are very slow-growing, indolent, and might never actually cause symptoms in the patient's lifetime. Let's call them turtles.
Okay, rabbits and turtles.
Now, screening programs happen at intervals. Say you invite a patient for a scan once every 3 years. Because the turtles move so slowly, they exist in the body for a very long time, which means your 3-year screening net is highly likely to catch them. But the aggressive rabbits grow so fast that they often appear, grow, and become symptomatic in the interval between your scheduled screens.
So a patient goes for their scan, they get a clean bill of health, and 18 months later they are in the emergency room with aggressive symptomatic cancer.
Exactly. The illusion created by length time bias is that the screening program looks incredibly successful on paper because it catches hundreds of these slow-growing turtles. The survival rate for the screen-detected cancers looks phenomenal. But in reality, the program is disproportionately missing the aggressive rabbits, the interval cancers, that are actually driving the mortality rate.
It makes the screening program look heroic because it's mostly catching the easy targets. And the second major illusion.
The second is lead time bias. Imagine a patient who has a hidden cancer. Based on the biology of the tumor, this patient is destined to die at exactly age 70. Without any screening program, the tumor grows silently until the patient develops symptoms at age 68. They go to the doctor, get diagnosed, and they live for 2 years before passing away at age 70. Their survival time from diagnosis is 2 years.
Okay, 2 years.
Now let's introduce a screening program. The patient gets a scan, and the technology is amazing. It detects the cancer incredibly early when the patient is just 62 years old. They receive treatment, but the treatment cannot alter the ultimate biological outcome. The patient still dies at exactly age 70.
Let's look at the math there. Their actual lifespan, the number of days they walked the earth, did not increase by a single minute.
Not by a minute. But look at what happens to the statistics. The medical registry now shows an 8-year survival time for the point of diagnosis, age 62 to 70, compared to the old 2-year survival time, age 68 to 70. The administrators of the screening program will proudly point to the data and claim they have massively improved survival rates.
But they haven't extended the patient's life. They've simply extended the amount of time the patient knew they were sick. They increased the duration of the disease without delaying the time of death.
These two illusions, length time bias and lead time bias, are at the absolute epicenter of the intense, ongoing medical debate surrounding breast cancer screening. The literature references the work of researchers like Peter Kusher from the Nordic Cochrane Center, who have rigorously and controversially challenged established national screening panels.
It is a fierce, highly technical debate. On one side, established authorities point to randomized trials showing a genuine, albeit sometimes small, reduction in breast cancer mortality due to mammography. On the other side, critics argue that once you mathematically adjust for length time and lead time biases, the mortality benefits shrink significantly. They argue we are not properly weighing the harms. The cumulative radiation risks of decades of scans, the immense psychological terror of the inevitable false positives, and the physical mutilation of unnecessary biopsies for slow-growing turtle lesions that never would have harmed the woman.
And if the breast cancer debate is fierce, the debate surrounding prostate cancer screening is the ultimate textbook example of the dangers of overdiagnosis. The data surrounding prostate cancer is unique. Autopsy studies consistently show that a massive percentage of men who die in their 80s from completely unrelated causes like heart attacks or strokes had prostate cancer at the time of their death and absolutely never knew it. For many older men, prostate cancer is the ultimate slow-moving turtle. They die with it, not of it.
So imagine you are a junior GP. A healthy, asymptomatic 60-year-old man sits in your office and says, "Doc, my buddy just got diagnosed with prostate cancer. I want the PSA blood test just to be safe." Human psychology screams at you to just order the blood test. It takes 2 seconds, it makes the patient happy, and it feels like you're being proactive. But the epidemiological data is begging you to put the pen down.
Precisely. Because of the massive risk of overdiagnosis, screening asymptomatic men with PSA tests is widely advised against in major public health guidelines. If you run that test on that healthy 60-year-old, there is a very high chance you will find a slightly elevated marker. That false alarm leads to a prostate biopsy, which carries risks of infection. If the biopsy finds a slow-growing, harmless urethral cancer, the patient will almost inevitably demand treatment.
And those treatments are not benign.
The treatments for prostate cancer surgical removal or radiation carry severe, life-altering side effects, primarily high rates of urinary incontinence and erectile dysfunction. By granting the patient's wish for a simple blood test, you may have just initiated a cascade of medical interventions that leaves a perfectly healthy man impotent and incontinent, all to treat a cancer that never would have shortened his life. The treatment harms in asymptomatic populations often far outweigh the theoretical benefits.
On the brighter side of the spectrum, look at cervical cancer screening. From a purely logistical standpoint, it has been a massive operational success. Countries that have implemented advanced call-and-recall IT systems to systematically invite women for regular pap smears have seen massive, undeniable reductions in cervical cancer mortality. They are catching precancerous lesions and removing them before they mutate.
But, as the literature notes, it is an incredibly resource-heavy endeavor. In one UK economic analysis, researchers calculated that the health system had to continually screen 1,000 women for 35 consecutive years and surgically treat dozens of suspicious precancerous lesions along the way, just to save one single life.
It is the definition of a heavy logistical lift. But this specific landscape is actively, wonderfully changing right now due to a return to upstream engineering, the HPV vaccine. By vaccinating the population against the human papillomavirus, which is the root cause of the vast majority of cervical cancers, we are neutralizing the threat before it ever enters the body. As these fully vaccinated cohorts age into adulthood, the incidence of the disease will plummet, and the need for this incredibly resource-heavy downstream screening apparatus will gradually reduce. It is a perfect example of an upstream technological intervention fundamentally altering the required downstream policy landscape.
Which raises a fascinating question. If a screening program is proven to be resource-heavy or mathematically ineffective or even actively harmful, like early population-wide PSA screening for asymptomatic men, why is it so incredibly difficult for a government to simply turn off the machine?
This brings us to a phenomenon the literature explores deeply, the popularity paradox. Why can't we just stop bad policies?
Because policymakers are human, and they are trapped by a fascinating, troubling psychological feedback loop called the popularity paradox. It functions like this. The more a poorly designed screening program overdiagnoses harmless conditions, the more it finds those slow-growing benign turtles we talked about, the more healthy people are unnecessarily pushed into surgical and chemical treatments.
And after those people endure the surgery or the radiation, the doctor shakes their hand and says, "We caught it early. We cured you."
Exactly. So those individuals genuinely, fervently, and understandably believe that the screening program saved their lives. In reality, the biological data proves that the condition never would have progressed to harm them. But the patient doesn't know that.
How could they?
By overdiagnosing them, the health system has inadvertently manufactured a massive, highly motivated, incredibly vocal advocacy group of cancer survivors. And when a health economist or a politician looks at the data and tries to shut the harmful program down, this army of survivors marches on the Capitol, goes on television, and fights tooth and nail to protect the program, believing they are saving others.
The paradox is brutal. The more physical harm and overdiagnosis a screening program causes, the more politically popular it becomes. That is profound and terrifying. The historical analysis provides a stark, undeniable example of this from Japan regarding child neuroblastoma screening. Neuroblastoma is a very rare childhood cancer. In 1985, fueled by good intentions and early, flawed data, Japan rolled out a massive national screening program to test infants for it.
However, as the global scientific community evaluated the ongoing data, it became glaringly obvious that the program was a failure. By 1990, international expert panels had conclusively proven that the screening was entirely useless at reducing mortality. Even worse, it was actively causing harm because surgeons were performing unnecessary, dangerous thoracic and abdominal surgeries on infants to remove benign masses that would have naturally regressed on their own.
The science was settled in 1990. The program was hurting babies. So how long did it take the Japanese government to turn off the machine?
Because of the popularity paradox, entrenched bureaucratic inertia, and the sheer political terror of being the politician who cancels a cancer screening program for babies, it took until 2004. It took 14 years after the definitive proof of harm for the national government to finally shut the program down. And they only managed to execute the shutdown by utilizing incredibly careful national governance, avoiding the creation of localized advocacy groups, and managing the media narrative with extreme caution.
That's unbelievable.
Another striking example of administrative inertia is Denmark. They continued mandating routine tuberculosis chest x-rays, which exposed the population to very real cumulative radiation cancer risks for 2 full decades after the tuberculosis pathogen had essentially been eradicated from the general population. The machinery of health policy is heavy. Stopping a bad program is sometimes vastly harder than starting a good one.
As we broaden our scope from the specific failures of screening to the modern macro policy challenges facing developed nations today, the literature forces us to look at the current crises. We've praised the historical victories over traffic fatalities and tobacco, but what about the battles we're currently losing? Let's look at the global crisis of obesity. The analytical consensus is that public health policy regarding obesity has largely failed over the last 3 decades because it relies on a flawed foundational premise. It treats obesity almost entirely as a failure of individual behavioral willpower.
Relying on individual behavior modification, telling people in a 15-minute clinical consult to simply eat less and move more, is a strategy mathematically doomed to fail when the entire population is immersed in what we call an obesogenic environment.
We're fighting against our own world.
Over the last 50 years, we have completely engineered our physical and economic world. We have created ubiquitous access to hyper-palatable, highly subsidized, incredibly calorie-dense ultra-processed foods. Simultaneously, we have utilized technology and urban design to essentially engineer all obligatory physical activity out of our daily routines.
So policy fails because it is asking the average citizen to rely on finite individual psychological willpower to fight against a perfectly optimized multi-trillion-dollar environmental machine designed to make them consume calories. To actually move the needle on obesity, you cannot rely on clinical advice. You require upstream environmental engineering. You need aggressive urban planning that prioritizes human movement and robust economic regulation of the food supply chain.
And if we are talking about the ultimate environmental challenge, the literature positions habitat degradation and global climate change not just as ecological issues, but as the single greatest impending public health hazard of our time. But the policy framework offers a remarkably elegant strategic concept called double dividends.
How does that work?
The concept of double dividends is a masterpiece of systems-level policy design. It involves identifying interventions that simultaneously solve 2 massive, seemingly disparate problems with a single action. For example, consider urban policies that heavily invest in and promote active transport building, extensive, safe, dedicated infrastructure for walking and cycling, while penalizing inner-city car use. This single policy intervention yields a double dividend. It dramatically reduces the carbon emissions driving climate change, and it massively reduces the population's risk for cardiovascular disease and diabetes by seamlessly integrating physical activity back into the daily commute.
Another brilliant example is agricultural policy aimed at reducing the mass consumption of red and processed meats. Subsidizing plant-based agriculture lowers the astronomical greenhouse gas emissions and water usage associated with industrial livestock farming, and it simultaneously lowers the population's baseline risk for non-communicable diseases like ischemic heart disease and bowel cancer. It's about finding the pressure points where ecological health and human biological health perfectly overlap, which perfectly sets the stage for our final major topic. We need to look beneath the surface interventions and examine the wider determinants and political economy of health. We are looking for the causes of the causes. And the text makes a very subtle but absolutely vital statistical distinction here. We have to differentiate between the forces that determine health inequality within a single population versus the forces that determine the average health of the entire nation.
This is an analytical trap many trainees fall into. Much of modern public health literature focuses intensely on the social gradient, studying why the poorest citizens in a city have worse health outcomes and shorter lifespans than the wealthiest citizens in that same city. That is the study of inequality.
Right.
But if we want to understand why some entire countries perform better than others on average, we have to look beyond just the internal wealth gaps. To return to the U.S. paradox, the epidemiological data shows that the U.S. disadvantage is experienced across almost all social strata. It's not just that poor Americans are sicker than poor Europeans. It's that wealthy, highly educated, insured Americans actually have worse baseline health outcomes than wealthy, educated Europeans. Therefore, internal income inequality alone cannot explain the national average deficit.
So if it's not just about money, what drives the national average? The literature points towards societal values. They reference large-scale sociological tracking projects like the World Values Survey, which maps how societies shift over time from survival values toward self-expression values.
The working hypothesis in the policy analysis is that once a society attains a certain baseline of material security and physical safety, its cultural focus can shift. It can afford to prioritize broader self-realization, environmental protection, and longer-term collective well-being. These self-expression values heavily correlate with the implementation of robust, upstream public health policies.
That makes sense.
It is fascinating to note that when you analyze the post-communist states we discussed earlier, the countries that eventually managed to turn their adult mortality crises around and achieve the best health outcomes, nations like Slovenia and the Czech Republic, are the exact same nations that score the highest on the sociological indexes for self-expression values. Culture dictates policy, and policy dictates lifespan.
We also have to reckon with a major structural determinant of health that is entirely man-made: corporate power. The epidemiological analysis does not mince words here, and again, we are purely relaying the textbook's neutral structural analysis. They highlight the 2006 U.S. legal case against Philip Morris, which resulted in a RICO conviction. For those unfamiliar, a RICO stands for the Racketeer Influenced and Corrupt Organizations Act, a law originally designed to prosecute the mafia. The federal court found that the tobacco industry had engaged in a decades-long coordinated conspiracy to manipulate cigarette design to enhance addiction and systematically suppress scientific research regarding cancer risks. But the broader, more profound argument the literature makes is that from a structural standpoint, corporations are not inherently evil entities. They are simply legally mandated algorithms.
That is the exact analytical framework to use. The corporate structure, by its very legal definition in a capitalist system, is strictly mandated to prioritize and maximize financial returns to its shareholders above all else.
Yeah.
Therefore, a corporation will systematically, predictably devalue any objective that is not legally monetized within its operating environment. And public health is the ultimate unmonetized externality. Whether we are analyzing the tobacco conglomerates, the global alcohol industry, or the multinational corporations engineering ultra-processed foods, they essentially function as highly efficient vectors for non-communicable diseases, simply by ruthlessly fulfilling their legal and economic objectives. The central challenge of modern public health policy, therefore, is figuring out how the state can regulate and harness that immense economic power without destroying the free market.
Which brings us to the ultimate philosophical bedrock. Why do nations choose the specific regulations they do? It all comes down to the competing models of political economy frameworks.
The policy literature contrasts two dominant philosophical camps that dictate global health architecture. On one side, you have the neoclassical and Austrian economic models. To understand this, look at the work of economists like Gary Becker, who championed the theory of rational addiction. Becker posited that consumers are utility-maximizing, rational agents who are constantly weighing costs and benefits. In his view, even entering into an addiction is a calculated choice made by the individual, and the state should be incredibly hesitant to interfere with that market transaction.
And there's Hayek's influence, too.
Yes, you also have the profound influence of Friedrich Hayek and his concept of catalaxis. Hayek revered the spontaneous organic order of free markets. He harbored a deep, abiding suspicion of central planning, or what he called constructivism, the arrogant belief that an elite group of scientific or medical experts could perfectly engineer society from the top down. This philosophical framework is the intellectual bedrock that fuels the U.S. resistance to sweeping public health regulation.
And standing in stark opposition to that.
On the other side, you have the evolutionary or heterodox economic models, championed by thinkers like Jeffrey Hodgson. This framework rejects the idea that humans are perfectly rational, utility-maximizing Homo economicus calculators. It embraces biological pluralism. It argues that human beings have objective, non-negotiable biological needs such as clean air, uncontaminated water, and baseline nutrition, and that these objective biological needs must supersede subjective manufactured market wants.
So they view regulation as protection.
Precisely. The heterodox model argues that because humans are psychologically vulnerable to highly engineered market forces like addictive algorithms or hyperpalatable foods, collective action and meticulously designed state institutions are absolutely necessary to protect population health from catastrophic market failures. This is the philosophical engine driving the piecemeal social engineering we see heavily utilized in European policy.
It is truly breathtaking to realize how deeply a purely abstract economic philosophy, debated by academics a century ago, directly dictates the statistical probability of whether you will live to see your 80th birthday today. We have covered an immense expanse of territory in this deep dive. We have analyzed the soaring, engineered successes of traffic safety, walked through the agonizing, counterintuitive math of false positives in population screening, and navigated the massive philosophical battles over state intervention and individual liberty.
We promise you a clear conceptual framework at the start of this hour. Hopefully, as you reflect on this, you can now clearly trace the intricate, undeniable links between abstract risk, environmental exposure, structural intervention, and ultimate system impact.
Before we move to our review questions and wrap up, we want to leave you with a final provocative thought. Something that builds on the foundational history we've discussed, but looks directly at the horizon approaching us right now. We are rapidly entering an era defined by AI-driven predictive analytics and incredibly cheap direct-to-consumer full genome sequencing. The technological and financial barriers to testing yourself for almost anything are dropping to zero. You can swab your cheek at home and look for hundreds of genetic markers. So the question you need to ponder is this: will this explosion of hyper-accessible testing create a glorious golden age of highly personalized upstream prevention? Or, based on the math of specificity we just learned, will it trigger the ultimate popularity paradox? Will it unleash a global tsunami of false positives, rampant overdiagnosis, and crippling medical anxiety that completely bankrupts the very hospital and welfare systems developed countries has spent the last century painstakingly building? Think deeply about that math as you watch the medical landscape evolve over the next decade.
It's going to be a fascinating decade to watch.
Now, to ensure these critical frameworks have truly anchored in your memory, we are going to run through 5 rapid single best answer prompts. I will read the clinical or policy scenario, pause for a moment to let you lock in your answer, and then provide the solution along with the chapter reference. Question 1. Imagine a scenario where you are a GP. You offer a PSA blood test to a 60-year-old man who presents to your clinic explicitly complaining of nocturia, or frequent nighttime urination. Based on our strict definitions, is your action an example of screening, surveillance, or case finding? Answer: case finding. Because the patient has presented with a specific clinical complaint, this is an opportunistic investigation of an individual, not population screening. You can review Chapter 11.4 Concepts in Screening for more on this crucial distinction. Question 2. In a population with an extremely low baseline prevalence of a specific disease, applying a screening test that is both highly sensitive and highly specific will still mathematically result in which of the following outcomes? A, a high positive predictive value. B, a low number of false positives. C, a low positive predictive value. Answer: C, a low positive predictive value. Remember the car alarm analogy. Low prevalence means the sheer volume of healthy people moving through the system will generate enough statistical false alarms to completely drown out the true positives, resulting in a low PPV. Revisit the math in Chapter 11.4, Properties of Screening Tests.
That math is essential.
Question 3. A newly implemented, highly publicized cancer screening program appears to vastly improve the average survival time measured from the exact point of diagnosis to the point of death. However, the overall population mortality rate for that specific cancer remains entirely unchanged. What epidemiological bias explains this illusion of success? Answer: lead time bias. The advanced screening technology simply moved the time of diagnosis backward, increasing the duration of known illness without actually extending the patient's biological lifespan. Reference the critical analysis in Chapter 11.4 Cancer Screening.
A classic illusion.
Question 4. According to the highly successful Victoria, Australia model of traffic safety engineering, what specific structural mechanism provided a massive, direct, self-sustaining financial incentive for the state to reduce road injuries? Answer: a mandatory no-fault compensation system managed by the Transport Accident Commission. Because the TAC was legally obligated to pay for all injury rehabilitation, they were financially forced to aggressively fund upstream prevention to save themselves from bankruptcy. See Chapter 3.7, Road Traffic Injuries.
The system's thinking at its best.
Question 5. What specific psychological and political phenomenon explains why public advocacy often remains incredibly strong and vocal for a screening program, even after international panels definitively prove the program causes severe harm through widespread overdiagnosis? Answer: the popularity paradox. Individuals who are overdiagnosed with harmless lesions falsely, but genuinely, believe the program saved their lives, inadvertently creating an army of vocal advocates who fight to protect harmful policies. Review Chapter 11.4, Evaluating, Restricting, and Stopping Existing Programs.
Mastering those concepts will fundamentally change how you evaluate medical evidence and health policy. Thank you for dedicating your time to engaging with this incredibly complex, vital material.
Yes, thank you for joining us on this deep dive. Keep questioning the systems around you. Here are the details of this episode.
Public health policy in developed countries. Byline: when systems are established, reform becomes the new frontier.